before you proceed with that. Here is the section of the heart. We salute our heart. Yes, the heart that beats without taking any rest. The slide displays section of the heart with two ventricles and two atria, AV walls, tricuspid and mitral, pulmonary and aortic walls, and the great vessels emerging from the ventricles. That is pulmonary artery from the right ventricle and the aorta from the left ventricle. So here is the slide showing phases of the cardiac cycle. This is very important slide showing the cardiac cycle. As you can see, cardiac cycle is divided into atrial systole, ventricular systole, which is again divided into first phase and the second phase, ventricular diastole, early and late phases. Yes, cardiac cycle begins with the atrial systole and ends with the ventricular diastole. Right? Atrial systole is characterized by is nothing but the contraction of the atrial chambers, which should empty their blood into the ventricles. Well, here the atrial systole, as you can see, it corresponds to the P wave of the electrocardiogram. This is followed by ventricular systole, the first phase. It is associated with the contraction of the ventricles, okay, and pushes the AV walls to close so that blood will not flow from the ventricles into the atria. And in the early phase of the ventricular systole, AV walls close, ventricular semilunar walls remain still closed. This corresponds to the isometric contraction phase of the atrial ventricular systole. As you can see, this phase, early phase of the ventricular systole, corresponds to the QRS complex of the ECG. The next phase is the ventricular systole, that is second phase of the ventricular systole, wherein semilunar walls open and blood is pumped into the great vessels. AV walls remain closed. This corresponds to the T wave of the electrocardiography. Then comes the ventricular diastole, early phase, followed by late phase. The early phase of the ventricular diastole, semilunar walls close so that blood, while the ventricles are relaxing, blood will not get back into the ventricles. At this stage, the atria gets slowly filled up. In the late phase of the ventricular diastole, AV walls open and blood flows passively into the ventricular chambers. So this is in brief the various phases of the cardiac cycle. Right. It begins with the atrial systole, ends with the ventricular diastole. The total duration of the cardiac cycle is 0.8 seconds and the heart rate is 72 per minute, out of which systolic phase is shorter than the diastolic phase. Then let us proceed with the auscultation of the heart. When the student is asked to auscultate the heart of the patient, he requires to have excellent hearing ability, and he should have the ability to identify subtle differences in pitch and timing of the sounds and murmurs. The student should use the diaphragm for the high-pitched murmurs, and bell of the stethoscope should be used for low-pitched murmurs. And patient has to be examined in supine position, supine and lateral, left lateral position, and in sitting and leaning forward position. And he should be examined in the left axilla. Student should auscultate in the suprasternal area as well as over the carotids. Now, after doing so, you should appreciate the heart sounds, the murmurs, and the rubs. Heart sounds are brief sounds caused by opening and closing of the valves. They could be systolic or diastolic. You should appreciate the murmurs, or the results of the blood flow, turbulence generated through when the blood is passing through the tissues. So longer than the sounds, they have the grading, which is based upon the loudness, the pitch, which depends upon the velocity of flow of blood, the location of the murmur, radiation, okay, etc. You should also appreciate rubs, which are high-pitched, scratchy sounds. Now let's go to the heart sounds. Heart sounds are, you can listen to the heart sounds. They are like lub, dub. This is first heart sound and second heart sound. And there is third heart sound and the fourth heart sound. We can put the heart sounds classified into systolic sounds and the diastolic sounds. You can see in this slide the sonographic pattern of the heart sounds. There is first heart sound with higher amplitude of the sound. You can see the second heart sound, third heart sound, and the fourth heart sound. The amplitude denotes the loudness of the murmur. So first heart sound is louder than the second heart sound. Third heart sound is louder than the fourth heart sound. Lub dub, lub dub, as the sound of first and the second heart sounds respectively. So as I told you, sounds can be classified into systolic sounds and diastolic sounds. The systolic sounds are first heart sound and the clicks. First heart sound is the result of the closure of the airway valves. Mitral valve closure contributes to major part of the first heart sound, followed by tricuspid valve to some extent. Mitral valve closes early, followed by the tricuspid valve. It is very difficult to appreciate the spirit of the first heart sound. It is high-pitched, loud in mitral stenosis, diminished or absent in mitral regurgitation. It is loud in mitral stenosis because The valve leaves are thick and they're stretched apart for a longer time and close suddenly, thereby resulting in loud fassa sound. Then clicks. Clicks are mainly systolic. They are again divided into ejection and non-ejection clicks. They are short and high-pitched, follows the first heart sound. Especially appreciated in aortic and pulmonary stenosis in mild to moderate degree, with the leaflets being pliable. Late clicks are heard in mitral valve prolapse and mid-systolic in myxomas of the mitral valve. So these are like this. You can see click is short, high-pitched one. Okay, it precedes the ejection systolic murmur. If the click is closer to the first sound, it is tighter the stenosis. So what are the ejectional clicks? What is the mechanism? Clicks are due to the abrupt doming of motion of the valve coming to abrupt halt at the onset of the ejection. This can be observed in echocardiography. In aortic stenosis, uh, the ejection click is appreciated, especially in bicuspid valve. If the ejection click occurs early, severity of stenosis is more severe here. The severity of aortic stenosis is closer the click to the first heart sound. This slide shows the ejection click could be aortic or pulmonary. It can have the valvular or vascular component. But as I tell you, I insist one point at this point of time that the mild and moderate stenosis only you can appreciate the click. It is the valvular stenosis that is associated with the ejection click, not the subvalvular or supravalvular. When you are dealing with the aortic stenosis and when you appreciate the ejection click, it is most probably valvular stenosis, not the subvalvular or supravalvular stenosis. Non-ejection clicks are generally seen in mitral regurgitation. They are heard all over the pericardium, not localized. The intensity of the click varies with the position of the patient. So as I told you, these are the features of non-ejection click. They are sharp, high-frequency clicky sounds, confined to a place but transmitted widely on the pericardium. They can occur in middle or late systole. Shows variation with respiration and also variation with beat to beat. usually single but could be multiple. So these are the features of non-injection clicks. Then we proceed with the diastolic sounds. The sounds that follow the second heart sound are the diastolic sounds. That is the cardiac cycle that begins with the second heart sound and ends with the first heart sound is the diastolic phase. What are the diastolic sounds? Second heart sound, third heart sound, and fourth heart sounds are the diastolic sounds. Then diastolic knock or diastolic thread. And one more thing is the diastolic, out of the diastolic sounds, you can appreciate the uh, opening snap. So what are the diastolic sounds? Second heart sound, third heart sound, diastolic knocks. So the mitral valve sounds, which is again, we can say it as the opening snap. The diastolic sounds are softer, low pitched, and longer in duration. This graph shows first heart sound, ejection click, second heart sound, then the diastolic sounds are following the second heart sound, opening snap, second heart sound, and third heart sound. So you have got the graph deflates systolic phase, diastolic phase, and the continuous phase, including both systolic and diastolic. So let us talk about the second heart sound. So second heart sound precedes the diastole. That means diastole continues with the second heart sound. It is caused by the closure of the aortic and pulmonary valves. Aortic wall closes earlier than the pulmonary valve. Right? You can appreciate the split of the second heart sound in predominantly left bundle branch block. Okay. And split is also appreciated in atrial septal defect. Yeah. In atrial septal defect, the split of the second sound is wide and fixed. Whereas in large left to right stands, second heart sounds could be wide or variable. Reverse splitting is appreciated in severe aortic stenosis because aortic wall closes later than the pulmonary wall, resulting in the reverse splitting of the second heart sound. So second heart sound should be understood very carefully. Abnormal second heart sound is always pathological, right? It could be single or loud associated with the pulmonary hypertension. It could be wide and fixed split, which is the diagnosis of atrial septal defect. Wide and variable in large left to right strands. This we are going to touch upon while we are dealing with the murmurs and the related lesions. Third heart sound is soft low pitched, heard immediately after the second heart sound. It occurs early in the diastole, right? And right side gallop is appreciated in deep inspiration with the patient lying supine. Left ventricular S3 is appreciated in deep expiration, patient lying left lateral position. And third heart sound is physiological in children and pregnancy, abnormal in adults. This sound is produced by the early rapid filling of the ventricles, generating turbulence. Yes. Fourth heart sound is soft, low pitched sound, best heard with the bell of the stethoscope. It occurs in late diastole. This is due to the rapid filling during the atrial contraction, with the ventricle being poorly compliant. This is normal in adults but pathological in children. Then other one is the summation gallop. This is again a diastolic sound. It is nothing but the summation of the third and fourth sounds. It occurs at the same timing as the third heart sound, but it is louder. Sometimes palpable in the left lateral position. Diastolic knock or diastolic thud. This is loud thudding sound. The timing is the same as the third heart sound. It occurs due to in the early rapid filling of the ventricle, and the ventricles are poorly compliant due to constrictive pericarditis. The other diastolic sound is opening snap. This is short, high-pitched sound heard early in the diastole. Soon after the second heart sound. Best heard with the diaphragm of the stethoscope. Best at the left lower sternal. It is heard in mitral stenosis, the leaflets remaining elastic or pliable. Closer the opening snap to second heart sound, severe is the mitral stenosis. If the walls are sclerosed, the opening snap becomes soft and absent. And with the onset of the atrial fibrillation, opening snap disappears. Then, let us proceed with the murmurs. The student should describe the murmurs. So there is an acronym. It can be remembered by the students. This is SCRIT. S stands for sight. The sight of the murmur weight is best heard. That is whether at the mitral area or at the aortic area, pulmonic area, or tricuspid area. These are the four areas you have got to auscultate. So the site where it is best heard has to be described. C stands for character. Could be soft, rough, blowing, crescendo, or crescendo decrescendo. Then radiation. That is, radiation is conducted to the axilla or to the carotid cells. I stands for intensity. This is loudness of the murmur based upon which you grade the murmurs. Grade 1 is barely audible. Grade 2 is audible. Grade 3 is clearly audible but no thrill. Grade 4 is clearly audible, louder, associated with thrill. Grade 5, you can appreciate the murmur, the stethoscope barely touching the precardium. Grade 6 is the loud murmur you can hear even with the stethoscope little away from the precardium. This is how the grading of the murmur is done. Then P stands for pitch. It indicates velocity of flow of blood across the chambers. Velocity of the flow. The gradient is high, velocity is high. T stands for timing, either systolic, diastolic, or continuous. So what are the systolic murmurs? Systolic murmurs could be functional or organic. Then we talk about ejection systolic murmur. Under the functional murmurs, we are going to touch in the next slide. Ejection systolic murmurs. Turbulent flow across the narrowed or normal wall, appreciated in aortic and pulmonic wall stenosis. They are mid-systolic, have crescendo and decrescendo character. Severe the stenosis, more harsher the murmur, and longer the murmur will increase in crescendo phase. And decrescendo phase decreases. When the stenosis is getting increased, the murmur becomes more harsh and the crescendo phase is longer than the decrescendo phase. So like this. You can appreciate this ejection systolic murmurs. So first sound, there is ejection click, and there is a murmur. Like that, yes. Still's murmur is again a mid-systolic murmur, which is benign. Then you have got the regurgitant murmurs. They occur due to the retrograde flow of the blood from the ventricle into the atrium. The pansystolic murmur, louder and harsh, soft and sometimes soft and less louder, with their valve regurgitation is valve is not at all common, not at all closed. Yeah, closing. At times, usually louder and harsh, and at times they are soft and less louder, depending upon the severity of the regurgitation. At times, they are late systolic, as in mitral valve collapse. So you can see the first heart sound, second heart sound is normal. B shows ejection systolic murmur of heart stenosis. C, it is the pan-systolic murmur in mitral regurgitation. And early diastolic murmur, diastolic murmur in aortic regurgitation. Then you have the continuous murmur of patent ductus arteriosus. Diastolic murmurs. They could be early diastolic, mid diastolic, late diastolic. They are always pathological. Under diastolic murmurs, we try to understand, should know the Graham-Steele murmur, Carey-Coombs murmur, and Austin-Flint murmur. Graham-Steele murmur is early diastolic murmur heard in the pulmonary area. It is due to the severe pulmonary hypertension in cases of mitral stenosis. Carey-Coombs murmur occurs in acute mitral valvulitis. It is mid-diastolic murmur. So often associated with S3 gallop caused by the increased flow across the thickened mitral valve. And it disappears with the disappearance of the inflammation following steroid administration in mitral valvulitis. This is Carey-Coombs murmur, mid-diastolic in nature and soft and low-pitched. The other early diastolic murmur is Austin-Flint murmur. This is mid-diastolic murmur in patients with severe aortic regurgitation. The aortic regurgitated jet of blood impinges on the mitral valve leaflets, thereby causing narrowing of the mitral valve, resulting in mid-diastolic murmur. This is the echocardiography. You can see the jet of the aortic regurgitation, and there is narrowing of the mitral valve. Then let us talk about the shunt murmurs. They flow down the gradient at the site of shunt. Sometimes they could be away from the location of the shunt. So for example, ventricular septal defect is the shunt murmur. And this is heard at the location of the shunt, that is left lower sternal edge. Whereas atrial septal defect, the murmur is heard at the left second space, that is pulmonary area. This is the murmur heard due to at the pulmonary area, and the pulmonary wall being normal, it is a flow murmur occurring at the pulmonary area. Yeah, this is the flow murmur. This slide shows transsystolic murmurs, ejection systolic murmur, VSD murmur, how it is showing the variation. Typical VSD murmur is pan-systolic, and in muscular VSD, you see, the murmur is short systolic murmur. muscular VSD, it is short systolic murmur. Murmur ends before the second heart sound because the contraction of the ventricle results in the closure of the ventricular septal defect. Then, in the development of the pulmonary arterial hypertension, okay, there is wide spreading of the second heart sound. You see, P2 is later than the, much later than the A2. With the increasing pulmonary arterial hypertension, okay, pansystolic murmur becomes a sort of systolic murmur with P2 much delayed. With increasing pulmonary arterial hypertension, shunt murmur disappears, then you get the early diastolic murmur of pulmonary regurgitation. Whereas in patients with VSD and aortic regurgitation, there is continuous murmur. Then let us talk about the continuous murmurs. These are always pathological. And the diastolic component decreases with increasing pulmonary pressure. When the pulmonary and the aortic systemic pressures are equal, murmur disappears. And to talk about the pericardial drugs, they are high-pitched, scratching sounds, the systolic, diastolic, and systolic, they are triphasic, resulting from the rubbing of the inflamed layers of the pericardium. Best heard with the patient sitting and leaning forward. Well, when you are auscultating the heart for murmurs, it is always required to exclude functional murmurs, identify organic murmurs, take the supporting history and clinical signs. So, what are the red flag signs of the murmur? By which you say the murmur is pathological. Holosystolic murmurs, all holosystolic murmurs are pathological. Diastolic murmur is pathological. Abnormal second heart sound, loud or wide split, etc. The murmur is more than grade 3. Harsh in quality. Presence of clicks. Murmur in left upper sternal border. And murmur increasing in intensity when the patient is erect posture. These are the red flag signs of murmur. So, what are the 7 features of innocent murmur? They can be described in 7 S's. Remember this acronym. Short, that is not holosystolic. Soft, low in amplitude. Small, limited to a small area. Sensitive, changes with the position of the patient. Single, not associated with clicks. Sweet, not harsh sounding. Systolic, occurs during and limited to the systolic. These are the 7 S's of innocent murmur. Well, thank you for patient hearing. We will continue with the next class. If you are interested, it is quite interesting. Please subscribe to my channel, and we will meet again in the next class. Thank you.